Hello and good morning, everyone. Thank you all for joining us for this morning's Department of Laboratory Medicine and Pathology Grand Rounds. For those of you who don't know me, I'm Liberty Bonester. I'm the GYN and Breast Fellow. And this morning, it is my pleasure to introduce you all to Dr. Michele West-Harvey, our 2024-2025 Blood Banking and Transfusion Medicine Fellow Physician. For those of you who are not aware, Dr. West-Harvey actually has a long background in laboratory medicine, including multiple years working as a medical lab technician. Her education began at Nassau Community College in Garden City, New York, where she earned her associate's degree in science and mathematics, and continued on to graduating summa cum laude from SUNY Farmingdale with a degree in biosciences and molecular pathology, followed by a master's in public health from Walden University. Dr. Michele West-Harvey then went on to earn her medical degree from the Medical University of the Americas, where she earned multiple academic awards during her time there, including the Dean's Award for Highest GPA in Basic Medical Sciences, the American Society of Clinical Pathology Award for Academic Excellence and Leadership in Pathology, and the Golden Key International Honors Award. While in medical school, Dr. West-Harvey published annually, including publications accepted into the Journal of Oncology Medicine and Practice and Advances in Hematology and Oncology Research. She began her graduate medical education as an internal medicine resident at the Norwalk Hospital Internal Medicine Residency Program in Norwalk, Connecticut. However, I think her story speaks for itself, and many of you who know Michele personally, when I say that Dr. West-Harvey was meant to end up in pathology. On a personal note, I had the pleasure of entering as a PGY1 resident with Dr. West-Harvey, and from day one, her passion and genuine knowledge for lab medicine was very apparent. As such, she completed her pathology residency here at the University of Minnesota this past June of 2024. During her time as a resident, Dr. West-Harvey gave over 10 academic presentations and is currently involved in multiple active research projects, the topics which encompass the efficacy and institutional guideline usage of blood units in pre-surgical patients with positive complex antibody screens, and the implications of clinical qualitative variables on mortality prognosis in patients receiving granulocyte transfusions. While continuing her rigorous academic pursuits as a resident, Dr. West-Harvey also actively participated in resident medical school education, root cause analyses, and multiple quality assurance projects. Today, Dr. West-Harvey will be presenting on decreasing alloimmunization in the sickle cell population by diversification of the blood donor pool, necessities of minority representation in the blood bank. Dr. West-Harvey, thank you so much for presenting to us all this morning. Please begin when you are ready.
Thank you so much. That was a wonderful introduction and kind of nervous to hear somebody speak about you in that way. Hello and grand rising, everyone. I will be presenting on decreasing alloimmunization in the sickle cell population by diversification of the blood donor pool. And this came as an interest to me during my times that I did rotations in transfusion medicine. Because I was seeing a pattern where there were difficulties in finding compatible units for these patients, for patients in this population, because most of the donors were of a different ethnic background. So I started to, dive deep into this topic. But the case that I would like to start off with, I can click on this, just to set the tone for the presentation today. This was a very interesting case that I came across during my rotation. And everything that's highlighted in yellow will be the crucial parts of the case to take with you as we go through the presentation. So this was a case of a 48-year-old African-American male. Of course, he has a history of sickle cell. This slide is not his slide in terms of the CBC, the photograph is not his, but he has a history of sickle cell and past medical history of complement-mediated hyperemolysis that was treated with eculizumab. He also needed a therapeutic plasma exchange in 2019. Surgical history, he had femoral head necrosis that needed repair and an ependymoma spinal surgery. So these two surgical procedures were scheduled kind of close, and they came to us and wanted a consultation to essentially say, hey, do we need to do red cell exchanges? This patient's going to need some red cell units. And as we can see, he had a myriad of what I would call the, alphabet soup of antibodies. And so this presented to be a difficulty in finding units for him, to the point where we had to order something called a monocytic monolayer assay. And what this assay essentially is a predictor of hemolytic transfusion reactions. And if you have an index of less than 5, that's a low predictor or low risk of having a reaction. We did end up finding 4 units. None of them were less than 5%. So there was always that small risk of hemolysis in this patient. And this case is very common with many other patients that have sickle cell, and just want to start off with this just to set the tone of the patient population that is of interest in this presentation. I have nothing to disclose. And so what are the objectives of today's presentation? So we're going to discuss the origins and distribution of red cell antigens. We're going to discuss the pathophysiology of how alloimmunization occurs, the production of antibodies, discuss the current status of the blood donor pool, and evaluate if diversification indeed can decrease the risk of alloimmunization. Discuss some of the cost analysis of doing an extended antigenic matching, and what are the future potential applications in immunogenicity. There is an equation that can be used, just a future implication of applying that to determine health outcomes. And I want to address, and this wasn't in the email that was sent to everyone, but I do want to address what the racial barriers in the current social climate that precludes diversification of the donor pool. So to start off, I know everyone has gone through some form of education with learning about some things about red cells. So I just want to give just a basic introduction to what red cell antigens are. So we're going to first define what blood group systems are. So blood group systems are essentially defined by the presence or absence of red cell antigens. And these are closely linked to similar genes. So what are red blood cell antigens? So they can be carbohydrates. For the most part, they are carbohydrates. And these carbohydrates are conjugated to lipid and protein structures. There also are some red cell antigens that are only proteins. Can somebody mute, because I hear a dog? So sorry about that. So according to the International Society of Blood Transfusion, there are 45 blood group systems. And these systems are determined by 362 red cell antigens, and they are derived from 50 genes. So what is giving the variation of these red cell antigens? So as I mentioned before, these are carbohydrates, and based on how these carbohydrates are cleaved, based on how they are transferred, conjugated, there are enzymes called glycotransferases that are involved in the process of the cleavages and conjugation. So how these carbohydrates and the proteins undergo recombination, it can lead to variations in its expression. Now, these variations can be influenced by evolutionary pressures and contingent upon geographical regions. And I'll explain that as we go forward in this talk. So as we all know, one of the blood groups is ABO. And we know that O is the most common. AB is the least common. This graph basically shows the distribution of these ABO phenotypes based on ethnicity. And as you can see, yes, we have most groups that fall into O because it is the most common blood antigen or blood type. But as you can see, even with the scale as you go further down, there's still even differences based on ethnicity. And this is all also dependent upon genetic expression. So here's a blood group schematic of blood groups. showing each antigen within the blood groups. And as I mentioned before, you can have carbohydrates that are conjugated to either proteins or lipids. And as you can see here, you have some proteins that are bypassing the lipid layer either one time. You have some carbohydrates that blood antigens that are conjugated to lipids. And I want to zone in on two of these blood antigens. So as you can see here, RH is predominantly protein. I don't see any carbohydrates that are conjugated or attached to the protein structure. And this would be important to talk as we move forward to talk about RH and the variants and the partial expressions and these polymorphisms in that blood antigen. And as we can see here, the largest one that we have here is Duffy, passes the membrane 7 times, has a small carbohydrate that is conjugated to it. And this blood antigen is very important. As we look at the global distribution of Duffy, this is schematic of the frequency, the antigenic frequency of Duffy negative globally. And as you can see, the red concentration in Africa, we all know that Plasmodium is very common in that region. And so why do we see Duffy negative having a high frequency in that region? Well, as we can move forward, Duffy is important in terms of the binding of Plasmodium vivax. So you have Duffy binding protein is crucial for vivax to bind and enter into the red cell. But if you have an absence of this or polymorphism in this particular protein, it leads to resistance of the parasite to enter into the cell. So in that region where we saw the concentration of the red with the Duffy negative in that population, this is that evolutionary pressure to lead to why that frequency is high in that region. Those are the patients or the population that had absence of that protein also had a survival of that infection. And as we can see, just as we see antigenic frequency differences in Duffy, we can see that in other antigens as well. And I kind of highlighted some of the antigens that are really, really crucial in terms of their clinically significance in production of antibodies. And I only highlighted the Caucasian and the African ethnic groups. And I'm going to continue to use the word ethnic, even though sometimes race and ethnicity are used interchangeably, but I want to kind of stick with ethnicity. But as you can see, there are differences in the antigenic frequency. So if we have a donor pool that is predominantly Caucasian, and they have a higher frequency of a particular antigen, but it's absent or a lower frequency in one group, when that group gets exposed to that particular antigen, because these antigens can elicit an immune response, then we can have a higher risk of producing an antibody. So ethnic distribution of blood groups. So as I mentioned before, antigenic frequencies, they yield objective information about common phenotypes based on ethnic or even demographic distributions. And these antigens, like I mentioned before, they can elicit an immune response. And this can differ based on the immunogenicity or antigenicity. And in such, it's important to increase phenotypic matching. So that way we can reduce the risk of antibodies. So I am not a expert in immunology, and I was made aware that there are people in the audience that are, but I would like to just start by just giving a brief overview of what the pathophysiology of alloimmunization is. So this can be categorized into two different categories. You have responders versus non-responders. And there are gray areas with this. Just because someone can be classified as a non-responder doesn't mean that they can't be pushed into the responder category. But essentially, a responder is someone that elicits an immune response based on exposure to a foreign antigen. A non-responder, you can be exposed to the foreign antigen. It does not always guarantee that you would definitely develop an immune response. And even in some cases, a non-responder may be misclassified because there could have been an immune response in terms of production of an antibody, but we were not able to detect it. And that would also be something that I would mention further moving forward into this talk. So what are the factors that play a role in producing an antibody? Well, it starts off with immune priming. And the definition of that is essentially a patient is exposed to a foreign antigen, and the dendritic cells are able to take up the antigen, as we all have learned, takes up the antigen and then does antigen presenting to a T cell. So that's the priming. This usually happens based on studies more commonly in the spleen. And I know we're talking about sickle cell patients. And so I know the question would be, well, what happens when the patient becomes asplenic? Well, these processes happen early on in exposure. We know that children can be exposed to certain antigens when they're getting transfusions as children. So the priming part happens early on, even before the patient becomes asplenic. And what helps push this priming process forward is a pro-inflammatory state. That can be fever, infection. We know that sickle cell also has more of a pro-inflammatory state, but all of these can induce or influence the likelihood of developing an antibody. And then what is the role of HLA? Well, HLA can be implicated. It can also be anti-HLA independent as well. So once the priming process happens, now we have the CD4 cells that are activated, and that's called polarization. The T cells become specialized when they are presented with that specific antigen. And so I have the two categories kind of separate to go deeper dive into the cell signaling process that's involved in alloimmunization. So again, responders, non-responders. Can responders go to the left side? Absolutely. So this is a very gray area. However, I just wanted to separate it just so that everyone can have an understanding. So there are studies that show that there are subsets of T cells that are polarized. And this polarization is highest in responders compared to non-responders. After you have your priming, you have the polarization. The follicular T cells are crucial in antibody generation. And this is through production of your cytokines, IL-21 and 4. And then that will then stimulate the CD38 cells to then proliferate into plasma cells and then producing the antibodies. Now, in your non-responders, studies have said that there's a higher amount of Treg activity. And this is more pronounced through enhancement of hemin. Hemin is oxidized hemoglobin, and this is released from the cell when there's hemolysis, and we know that hemolysis is higher in sickle cell patients. And hemin activates the HO or the heme oxygenase pathway, and it also does that in your monocytes. Hemin also can play a role in inhibiting the plasma cells and therefore reducing or inhibiting the antibody production. Now, in a sickle cell patient, when the T cells become so polarized, you have the priming and the polarization, they become very specialized, and they have more and more exposure to foreign antigen, then the hemin can no longer inhibit that process. And so here's a diagram of what I just explained. And so if we start on the left side, we have the category of responders versus non-responders. And again, it is a gray area. You can be pushed to the responder side. And we have the priming starting with the dendritic cell. Like I said, this happens in your lymphoid tissue. particularly the spleen. You have activation of the T cells, and then the T cells then would activate the B cells to then proliferate to plasma cells, and then now you have your antibody production. And like I said, this can be influenced by a pro-inflammatory state, inflammation. It can be influenced by HLA. And then in your non-responders, you have inhibition of these processes due to exposure of hemin, as we can see on the left side. So going back to sickle cell patients, so we know that they have a high reliance on repeated transfusions, and they have this pro-inflammatory state that leaves them prone to the alloimmunization, as I mentioned before in the previous slide. So again, sickle cell patients have more resistance to hemin-induced enhancement of Treg function, which is associated with increased alloimmunization, and this is due to that strong polarization of the T cells. We also know because of this pro-inflammatory state, there's an increase of interferon alpha beta, and this also influences the alloimmunization in the responders. And this it's interferon alpha beta is also involved in and associated with delayed hemolytic transfusion reactions. So I always like to find two studies to basically confirm a hypothesis. So this is the second study that also discussed the pathophysiology of alloimmunization. This article discussed the limitations in finding antigenic similarities of blood units for sickle cell patients because of this polarization. You have the Th2 stimulation. There's decreased Treg function in these patients, and this leads to essentially antibody reduction. So the risk of alloimmunization in sickle cell patients, we know is associated with more transfusions. As I mentioned before, more exposure to the foreign antigen, more risk for alloimmunization. So the study then discussed, well, how can we mitigate these risks? And one of them is a discussion of antigenic similarities based on ethnic or demographic backgrounds. And we know in the westernized countries, as I have even stated, the donor pool is predominantly Caucasian. And the risk and the percentage, the prevalence of alloimmunization of minority patients in the US is 20 to 60%. And compared to a more racially homogenous population like Jamaica or Uganda, where the alloimmunization prevalence is 2 to 6%. There could be some confounding with the low prevalence of alloimmunization in those countries. Their blood products can be low quality. There's a lower amount of transfusions in those countries because of the low quality of products. However, there's some studies that still suggest that there should be more diversification regardless of that, as long as we can find more quality products. They feel that there's still a need for diversity, and I will go forward with that. Another way that we can decrease alloimmunization is by doing a prophylactic antigenic matching and extending that to include KIT, Duffy, and MNS. So you have your basic phenotype matching and then the extended. The basic is ABO, RH, and COW. But if we include more of the KIT, Duffy, and MNS, that way we can also decrease the risk of alloimmunization. And a study will go into showing that there are antigenic frequency differences in the groups that are included in the extended phenotype matching. And then another thing that the article discussed is RH compatibility. As I mentioned about before, that RH is predominantly all protein, and you can have some polymorphisms and variants and partial expressions of that. and that matching for that or doing some molecular testing can also decrease that risk in this population. So I wanted to throw up another schematic. It's essentially a repeat of the first one, but just to go deeper into this, again, we have the priming process. You have the antigen presenting to the naive T cell. Then you have the polarization. You have the Th2 that will stimulate the B cell and production of antibodies. But as you can see on the non-alloimmunization side or the non-responder side, they have the antigen presenting to the naive T cell, but you have Treg that has been upregulated in that, but they have some question marks there. And as I mentioned before about hemin can inhibit that process. There are some animal studies, and I didn't include any schematics from the animal studies, but they are doing some animal studies on infusing hemin into the mice to see if there can be more of an anti-inflammatory state to upregulate the Tregs, and it was positive in the mice models. However, I didn't see any studies in terms of using hemin infusions in the sickle cell population, and we have to understand that once these processes are so polarized and the T cells become very specialized, hemin may be rendered resistant in that population. So now we're going to talk about diversification in the blood donor pool. So currently, the rate of blood donors for Caucasians is 77 per 1,000, and then it's 22 per 1,000 for African Americans. And actually, recently that has even decreased. There's even less representation of African American Black in the donor pool. And we know that sickle cell predominantly affects the African American, Black minority population, heavily impacted by certain anemias like sickle cell. Thus, there's a high requirement of transfusions, based on how sickle cell is managed. So let's consider that these antigenic differences across these ethnic groups can induce deficits in ensuring that we are phenotypically matching, because this is the least represented group, and then this would increase, the risk of alloimmunization. So this is where the studies have come into, where I took a deep dive into. So I said, well, hey, are there any studies that examined where the donors were racially homogeneous and matched the patients, and what were the risk of alloimmunization? So some studies have shown that diversification can decrease the risk of alloimmunization. However, we also have to consider, again, that sickle cell has a pro-inflammatory state, and that in itself is a very complex issue in terms of handling that. So we're never going to get to 0% alloimmunization. We just want to decrease it. And that's the whole complexity that I was mentioning about immune complexities. But the current status, there's still a very disparaging. There's still a disparity in minorities donating blood, as I mentioned before. It is decreasing. Now, why this is? Can this be contributed to a distrust in the Black community for medicine, or can this be due to just simply racism in medicine? So here's a first study. Increased prevalence of alloimmunization in sickle cell. Should we restore blood donation in French Guiana? So French Guiana is located in South America. It is a French territory, so they are colonized. And they conducted a cross-sectional study between 1995 and 2016 to examine the rates of alloimmunization in their population. So they had to start using what they consider European blood products. What was going on in French Guiana was that there were a lot of transfusion-related infections. So there were a lot of patients coming down with Chagas disease, HTLV, and other viral illnesses that caused them to put a shutdown to doing local blood donations. And they actually completely shut it down in 2005. So they started to then get blood products from their, lack of a better word, their colonizers. And they also got some blood products from some local places. I believe it was Brazil, Guadalupe, to basically ensure that they had some blood products. So what they said, okay, so now that we are switching to predominantly European products, now we want to see if there will be a change in the alloimmunization rate in our population from 1995. So they monitored the number of units transfused, number of transfusions, what the indication of the transfusion, age, and history of pregnancy. The data did include an extended phenotype. So what I mean, again, that they included the KID, the Duffy, and the MNS. The types of alloantibodies, if there were any transfusion reactions, and then emphasis on hyperemolysis or delayed transfusion reactions. And again, they did extended genotype, antigenic phenotype, they did an extensive antigenic phenotyping and molecular testing only if there were rare antigenic variants. So this is just another graph of just the population that included children all the way to adults. They had a total of 451 patients from 6 months to adulthood, and they did electrophoresis just to confirm that they did, in fact, have the sickle cell disease. Again, they did extended matching, especially what that was performed if the patient had 2 or more alloantibodies. Antibody screening was done, and if required, molecular testing for genotyping. So here are some of the study outcomes. So the common phenotype, actually, it'll be, yes, the common phenotype seen in this population, as you can see, it was D positive, C neg, big C neg, big E neg, and little C positive and little E positive. This is a common phenotype for the African American population. It was seen in 51% of the study group. 40% of them had some form of variant in these RHD antigens, and 66% of the study participants had absent Duffy, as we had discussed about the Duffy absence because of the Plasmodium vivax. And that evolutionary pressure. So that to me was not surprising. So out of all the transfused patients, 23% of the participants developed alloantibodies, and 19% of these patients developed delayed hemolytic transfusion reactions. And they defined their delayed hemolytic transfusion reaction as a drop in hematocrit along with a positive antibody screen and a positive direct Coombs test. And I would discuss that later on, how this definition can be changed in some other patients, but that I would definitely discuss later on. So of the patients with delayed transfusion reactions, Duffy antibody was implicated. And I have a graph here to show the number of alloantibodies respectively and the total percentage. And as we can see, Lewis was the highest. You did have some allo to RH and the MNS. So those fell to be the highest. I felt this graph here was really, really important to explain, give you the picture of in the study. So we have the temporal evolution of the number of packed red cells. And I put an arrow at the year that they started using the European blood products in 1995, even though they were using some blood products from other countries, but they were taking them on more heavily. And then they stopped doing the local blood donors in 2005, but this is when they started using it. So I made sure I put an arrow there. So the top graph is the temporal evolution of number of packed red cells. And as you can see, as they started to get more blood products from France, they started to use more. So there were more transfusions over time. The bottom graph shows the number, the temporal evolution of number of alloimmunizations. So as you can see, the arrow 1995 when the study started, when they started using more of the European blood products, and then over time, the number of alloimmunization cases also increased. So you see a very relational between increased number of packed red cell units and a number of alloimmunizations. And the patients who were alloimmunized to the non received more transfusions, and that was statistically significant. And so I wanted to also explain the delayed hemolytic transfusion reactions. And as I mentioned before, they said that Duffy was implicated in these delayed transfusion reactions. So I just put an arrow just to show you the highest number of allo antibodies in a delayed hemolytic for this study. So the study conclusions. They did show that there was a drastic rate of alloimmunizations that increased over time with more blood products from a non-ethnic population. Now, the study in their discussion did say that they understand that now the clinical management of sickle cell is transfusions. A patient comes in low hemoglobin, we are going to transfuse them. So, but what they said also is that before they started doing a lot of transfusion, they did an intensified usage of hydroxyurea. They did not give details as to what they meant by intensified usage or what that clinical management definition is. But perhaps they feel that, well, with the intensified uses of hydroxy, and then having the diversification of the donor pool, they want to restore local blood donations because they did see that there was much lower alloimmunization in their patient population. They also feel that it would have been even higher if they didn't do the extended phenotype matching. And that was including, like I mentioned before, the Duffy, the KID, and the MNS blood antigens. So here's a second study, pattern and prevalence of alloimmunization in the sickle cell population in Nigeria. And the conclusion of this study, I felt like it was really good to include this because they had a difference of opinion. And also, Nigeria is the epicenter for sickle cell. I've had some people that went to my med school that really talked about that being a major issue there. And we can see that just based off of the rate of patients born. So 1/3 of children born to Nigerian parents have sickle cell disease annually, and this is out of 300 born worldwide. So they have a higher amount of patients born there with sickle cell. And they too, they said, well, they know that these patients are going to need a lot of antibodies, a lot of transfusions. And they also noticed that there were studies that were conducted about diversifying the donor pool. So they also wanted to see what their study would conclude. So the study sought to examine whether racial disparities in donor recipients can mitigate the factors and impact alloimmunization in this population. So they did a prospective sectional study and included both adults and peds at the University of Nigeria. They divided the groups into two. So you had 80 sickle cell disease patients in group one. They had to have a history of previously being transfused 2 or more transfusions in their lifetime. And then they had a control group of 40 sickle cell disease patients who never received a transfusion. So both groups were transfused within a 4-week period of time, but they did not do extended phenotypic matching. So they just did the ABO, RH, and CAL. They didn't do the MNS and KID. And I would discuss why some places cannot perform extended phenotype matching. because there is a cost to doing this. And that would be discussed later on. So what were the outcomes of this study? So overall, prevalence of alloimmunization in both groups was 5% total, but 18.7% occurring mostly in the study group that was associated with blood transfusions. So they had three patients in the control group, the study group. No, three patients, one in the study group and two in the control group that developed autoantibodies. And I felt like that was really crucial as I move forward to discuss about the Rh variants. But none of the patients in the control group developed detectable red cell alloantibodies. And there was no significant difference between age and alloimmunization. Here's a graph. They also showed no statistical significance between the type of bodies and the age of the patients, and also the total number of transfused units, and also the age of patients as well. So these graphs, basically, there were no statistical differences between those two variables. But this graph I felt was really important because they said the most common alloantibody that they've seen in patients was the Rh. And this goes back to the point when I was talking about that protein and having those polymorphisms, that variant and that partial, that more likely is the cause of why there were alloantibodies in this patient group. And then I'll have a little study that would follow this to explain that. So what did the study conclude? Well, they said, well, we don't believe that there were, that race plays a role, racial differences in the donor and recipient plays a role in alloimmunization. However, I took some issue, with this study because I did not necessarily see a clear association between the ethnically matched units and the risk of alloimmunization. I think there was confounding in this study because they did not explain whether the history of the experimental group or the study group, where they got their units from in the past, right? There was no mention of, this patient got transfused here and it did not come from a ethnically matched. So I just felt like that also wasn't clear. They also mentioned that the alloimmunization percentage could have been an overestimate because their assays were highly sensitive. However, I do believe that the study conveyed the importance of not only antigenically matching, but transfusing a patient early in the management process. So as we can see with the control group, they said that there were no allo antibodies in the control group. They also never received a transfusion. So I was wondering, and they received racially matched units. So my thing was, is this a cause for an early intervention in making sure that these patients get exposed to racially matched units? And also the importance of extending the phenotype and then applying molecular testing to look for those RHD variants that are seen in the sickle cell population. And this took me to this study here, and this is just a really quick insert. So we have a retrospective study. This was done in Brazil. Brazil is also another country that also did a study on diversification of the blood donor pool, and they were pro-diversification. But they also did another study to include 48 Brazilian sickle cell patients and to examine the risk of alloimmunization in the Rh antigens despite phenotypic matching. So they did extensive molecular sequencing of the axon that was used to identify all of these Rh variants, and they also conducted some serological testing. And this study showed that 65% of the patients with Rh variants or even partial expressions developed alloantibodies, and 42% of the patients developed autoantibodies. And this was all and involved even in the delayed hemolytic transfusion reactions. So even if they did phenotypically match and did an extended match, these small variants and polymorphisms that are seen in this protein can still induce some form of allo and even an autoantibody that was involved in delayed hemolytic transfusion reactions. So I just wanted to add that part because of the previous study and what they had found. And I wanted to see if there were any other studies that examined how these variants and partials play a role in also producing alloantibodies. So I'd say the best study for last. I really like this study. So this study took place in Oakland, California, here in the United States. And they also wanted to see if there were any racial differences in the donor pool versus recipient, and what role does that play in alloimmunization for the sickle cell population. So all of the patients between 1978 to 1985, they had to have their care at the Children's Hospital, but they followed them, they included adults as well. So we had 158 Black sickle cell patients. And so what they did is they separated the Black patients from what they call the non-Black patients, and they wanted to see, okay, you have patients that have chronic anemia that would get transfused, as well as a sickle cell, and those who are classified as non-Black, do they have the same risk of developing an allo as the Black patients? So the chronic anemia patients had either some form of pure red cell aplasia or thalassemia. And they did the diagnosis of sickle cell anemia and thalassemia that was confirmed with the hemoglobin electrophoresis and some family studies. So study method, so they collected information regarding indication for transfusion, number of transfusion, and any evidence resulting from, the transfusion. They did include an extended phenotype. So they did include the Duffy kid and the MNS. And for those who did donate blood, they had them self-identify what their racial or ethnic backgrounds were. So they had 12,500 approximately voluntarily identified their racial backgrounds. So the study concluded some of the outcomes. So the non-Black chronic anemic patients, even though they were more likely to be transfused, they also did not develop alloantibodies, except for maybe one patient. But compared to the sickle cell patient, 30% of those patients developed an alloantibody. And for the patients that developed alloantibodies, they received on average 23 transfusions. 11% of the sickle cell anemia patients also developed delayed hemolytic transfusion reactions. Their definition again dropped in hematocrit with a positive direct Coombs test. And if we go to the percentage of the donor pool, 90% of the donors were Caucasian and 5% self-classified as Black. So here we have a graph of the study. So frequency, so we're going to start from table 1, frequency of alloimmunization amongst the patient population, sickle cell versus the chronic anemia. And I have it little boxed off. So this is the percentage of alloimmunization. And as we can see, there's a very statistically significant difference between the sickle cell population for the adults and children that developed an alloantibody compared to the chronic anemia patients that were classified as non-Black. Only one patient, or 5% of those patients, developed an allo. And then if we go to table 2, we're going to look at the number of transfusions. So the chronic anemic patients actually received more transfusions than the sickle cell anemia patients. As we can see, number of average is 131 transfusions, but for the sickle cell, we have an average of 23. And then the appearance of the first antibody for that population occurred after the 12th transfusion. So we're going to go to table 4, and I felt that this graph was really important to put in because this shows the disparities and the antigenic frequencies between the Black patients and the donor pool, which was 90% Caucasian. And I boxed the ones that were clinically significant. And these were the same antigens that I had even highlighted in the graph at the beginning of the talk when I was just showing the antigenic frequencies. And there were these antigens showed statistical significant difference in terms of their frequency. And this is important to show because again, this also means that the Black population, the sickle cell population, was exposed to essentially a foreign antigen that increased their risk of developing an allo. And then table 5 essentially showed that there was no statistical significance between the chronic anemic patients that were classified as non-Black and the blood donors. So there was more of a phenotypic match for the chronic anemic patients compared to the sickle cell patients. So what did this study conclude? Well, alloimmunization was highest in the Black group, or the Black the Black sickle cell population, in spite of having lower transfusions compared to the non-Black. And there were significant differences between the phenotypes in the Black group as compared to the Black donors, and this is evidence of a need for extended phenotype matching. And again, I would mention about what the limitations of that, is in terms for a laboratory expense. But this study further supports the probable need for diversification of the donor pool, especially in finding compatible units. So what are the overall conclusions and considerations of just the studies? So we know that there's an association between increasing number of transfusions with the development of alloantibodies. However, it may not be clear if it's entirely due to racial disparities in the donor pool, but we can still say that we can have a consideration for diversification. And also, extending antigenic phenotype matching can lower the risk of development of an alloantibody. And alloimmunization, including even forming of an auto, will always be a risk in the sickle cell population, but this is due to underlying patient factors and disease pathophysiology. And we can also state that molecular testing and genotype should be considered due to these RH variations and partial expression. So I thought a hypothetical question. So I said, well, evidence does show that there's more exposure to antigenic different blood associated with increased rate of alloimmunizations. But can one consider that exposure to antigenically different blood is driving the need for more transfusions? And I had posed that question to one of the blood bank attendings here. And the response was that alloimmunization does not always equal anemia. So I did do some research to see are patients misclassified, or can delayed hemolytic transfusion reactions be missed? And another question I have posed is, does early diagnosis of sickle cell, we know we do neonatal screening, but should that reflex to establish an extended phenotype early and prior to any transfusions decrease the risk of alloimmunization in the future? So I found this study. This is an oldie but goodie, I would say. It's in 1978. So just a really quick synopsis. So delayed hemolytic transfusions, can it often be missed? This goes back to when I was discussing about responders versus non-responders, right? I said that responders can be misclassified and be actually a responder, but their titers may not be detectable. The antibodies may not be detectable. So this study conducted over a 7-year period. They examined 8 Black patients with sickle cell, either hemoglobin SS or SC, who experienced what is considered an unexplained drop in their hematocrit post-transfusion. So the study found that in all patients that did develop an alloantibody, some of them were undetectable after 72 hours, with a third of patient titers falling to undetectable to 4 to 12 months. So let's go to the graph And this was one of the cases that was in this study that I felt was really, really interesting. So you have a 17-year-old boy who had hemoglobin SC. He had a really, really low hematocrit hemoglobin. So he just had his scheduled transfusion. So as you can see, the hematocrit did bump up, but after a few days, he just had an unexpected drop. So they did a direct Holmes and it was negative. So this would be, oh, is this a non-responder? But perhaps no. In this case, there was allo antibodies that were formed, but it just was not detected on testing. So they gave him another transfusion, and then that's when he had this acute hemolytic transfusion reaction. So he had full-blown hemoglobinuria, even to the extent where there was some renal failure. But then got another transfusion after they did some extended testing. And as you can see, his hemoglobin jumped up. So another thing that the study also is pushing is the need for maintaining records of all antigens exposed. Because there were some patients, because some titers can fall after a certain period of time, when they're going for another transfusion, later on down the road, recall that you already have this polarization, you already have this priming that had taken place, but the allo antibodies may not be at a detectable rate. And then they'll have this amnestic response where they'll get a transfusion and then boom, now we have full-blown high titers, and hemolysis reaction. So this leads me to the question, have there been a lot of misclassifications of patients that actually did have a delayed transfusion reaction? They had this unexplained drop in hematocrit with a negative direct Holmes. How often does this happen? I didn't find anything going forward, but this would just answer that first question of alloimmunization equaling anemia. Perhaps there could be some misclassification of patients. And now going to the extended matching and the cost of that. So in the United States, we have approximately 100,000 sickle cell patients. 30 of them are at risk of developing an allo. So the average cost for sickle cell treatment is about 500,000. I would probably even go up to $1 million. That would be my guess. I would think that with new development and everything, it'd probably even be higher. So this study used the Markov based modeling. So what's the Markov based modeling? It's essentially a mathematical schematic that is a predictor of outcomes. And how it does that is it uses the probability of an outcome based on past events or previous events. And Markov has been used for medical decisions. And I thought that was a very interesting model to apply in this study. So this study had a cohort of patients who determined cost effectiveness in conducting either prophylactic extending matching. That is what I mentioned before about neonates having some form of extended, matching or some genotype to see, okay, well, we know that what their genotype is early on, and then we would have to phenotype, match moving forward. So that's that prophylactic approach versus a prospective approach, meaning, okay, we know this patient got exposed to this antigen. Now we should do extended matching for that patient moving forward. So they wanted to see what the cost difference will be. Well, the numbers are really astonishing in terms of the cost. So we have the outcomes of both modeling strategies. So we have 76 million per year of for the prophylactic, and then 1.86 billion for the prospective. And it would avert approximately 2,000 versus 2,500 of the cases. So the average cost to avert a single case would be 370 to 700,000. But the cost of a blood drive is 39 to 5,000. And so I don't know why there's not more blood drives done in the Black community. But this would essentially, we would need to see what the impact of extended matching would be on healthcare. essentially. But I thought that this was a really good study. This is one of the preclusions as to why laboratories are not doing too much extending because it is very expensive. But I say, well, follow the money. I mean, health insurances are trading on the secondary market and everything. So again, and I know I have a short period of time, it's 9 o'clock. But I say follow the money. There are ways that we can work with our health insurances to avert these costs. So just really quick on the immunogenicity of using this equation to calculate immunogenicity. So what is immunogenicity? So it's based on the probability that an antigen negative recipient receiving a blood from a positive donor will lead to production of an antibody. And I felt like this equation can be used for something in the future as some form of AI or some form of informatics that can be applied into our EPIC that will be a predictor of what the production of an antibody would be. So let's say you have a patient and we have these units that they can use. We can apply their sequences, their antigenic phenotype into this equation, along with knowing what the donor pool is if we did diversify it, and then what the production of the antibody would be. So I'm just going to move really quickly forward. And then racism in medicine. So this survey was done at the APM laboratory, and they basically sent the survey out to some Blacks that were living in Minnesota and found that, essentially Minnesota, there's a higher percent prevalence of racism here compared to everywhere else in the United States combined. They didn't ask questions regarding healthcare per se, but it was just like, have you been discriminated in general? And I can say for sure that if it's happening in general and if it's this pervasive, it's more likely happening in the healthcare as well. So I believe that we need to fix this issue first before anything. Let's change the perspective and the stereotypes for Blacks, and let's focus on the community initiative by going into the community and promoting more blood drives. It's affordable. It's only $5,000. And then we can focus on, having a database of patients to know what antigens they've been exposed to, and then creating a financial plan. So here's my references. I would like to say thank you to everybody. Just a big thank you. Here's a picture of my kids. Here's a picture of my husband and my family. And if anyone has any questions, I would take questions.
Okay, hearing no questions. Anything else? All right, we will be done for the day. Thank you all for joining us. Good job, Michelle.
Thank you. Thank you,
And
everybody.
we will see you next week. Thank you.